if we step back for a second from all of the mechanisms of action of the drugs, we have this reality that very few people just have diabetes. You know, they either have another underlying disease state that hasn't yet been diagnosed, or they have a formal diagnosis. We were on a prior peer exchange panel with you, Tripp, and you had mentioned that you had started to administer PHQ-2s and PHQ-9s in patients with diabetes and saw this effect of, wow, this was a really good way for us to figure out who needed these additional supports. Right. Do you want to describe that? Because what I'm hearing is that it's actually pretty rare that you might have a patient that walks in that you're level setting with, that it's straightforward diabetes, right? Is there even straightforward diabetes? So this issue of all these comorbid states, and that to Dr. Morales' point, that you may focus on the severe and persistent mental illness as the issue of the day because it's very prominent and it has its effects. You may be focused on the heart failure or the cardiovascular disease because they just had a heart attack a few months ago. But in many cases for these patients that are diabetic, it's just this steady progression over time. How do you bring that diabetes to the fore in that patient discussion when so often there's these other comorbid states that within the minds of the caretaker or the patient may take precedent?
So that is the challenge, right? So the folks that come in that sit down with a pharmacist in our pharmacies are typically the most complex. So they've got multiple things going on. Patients tend to compartmentalize these things as well. And so they think, I'm going to manage my diabetes, I'm going to manage my cardiovascular disease. And one of the advantages that we have is therapy's already been initiated when they come in to see us. And so we get to have the talk. This is a marathon, not a sprint. Just because you completely overhaul your diet and you really change your lifestyle now, chances are it's like quitting smoking. You're gonna relapse at some point. So we really need to play the long game here. Another thing we do is we talk about the availability of the community pharmacy, all the touch points we have. So where patients may be in your office several times a year, we get to see these patients a lot, monthly, if not more often, and we're in their homes. So we try to leverage that in any way we can, also use the support system that's around us. And so with this patient that comes in with a new diagnosis, new regimen, talk to them about not only the longevity of how we can help manage this, but also bring in the support team from the community as well, whether that's the local health department with dietitians and bring those folks in. We enroll patients in our diabetes classes and so forth. One of our diabetes, and this I think is noteworthy here in this conversation, is one of our diabetes classes that we had. We brought in a speaker, and it was a local optometrist who had a daughter that was type 1 diabetic. She had, I think she was diagnosed at the age of 8 or 10. And so he gave a very compelling story, not only from his experience in doing eye exams, but also with his daughter. And he said, this is the only chronic condition that I can think of that can be solved up here, with lifestyle modification. And you think of hypertension and heart failure. You can't overcome a lot of it up here, but once you get going up here, you really can do a lot of good with lifestyle modification, exercise, and carb counting, and so on. So those daily challenges and getting family members in and really making this a team effort, that's where we hope we're bringing benefit to this whole package.
Well, I mean, that was actually pretty nicely depicted in a trial that was conducted. It's actually an NIH-sponsored trial called the Look Ahead Study. Mm-hmm. Patients that were intensively treated with lifestyle modification, reduced caloric diet, they had 0.6% reduction in A1C, but not only that, but their level of fitness improved by 10 METs, which is really impressive. So lifestyle really is the cornerstone. But aside from all of this, I mean, diabetes could be a pretty devastating illness, but it doesn't need to be. And I think most patients tend to feel recluse once they've been issued this diagnosis. But it's equally important to recognize how every member of the care team, including the nutritionist, including especially the pharmacists, play such an important role in ensuring adherence of therapies that are prescribed for our patients and to encourage them to continue on their journey towards good control.
With a lot of the touch points that we have in the community, we get to pick up on a lot of things, and I've failed to mention the depression screenings that we've done. That was one of our resident projects, and we've continued that on multiple times after. But a lot of people go in and they're diagnosed with diabetes, and they come out with medicine, but they come out with diabetes and depression. So those are things that we have to take into account as well, and not treat the illness, but treat the entire patient and try to look for these things that may have been overlooked, because the appointment may have been for diabetes, or may have been with an endocrinologist where they had a lot of other things going on that maybe are more acute. So it puts us in a really intriguing position when we get to sometimes send referrals for things that we pick up on in the community or even in the home that may have been overlooked because of the really hyper-focused appointment.